I'm Dr. Lawrence Leiter, an endocrinologist at St. Michael's Hospital in Toronto and professor of medicine and nutritional sciences at the University of Toronto. And it's my pleasure to talk to you today on controlling cardiovascular risk factors in 2021 beyond glucose. And here are my disclosures. As you're all aware, diabetes is a large and growing global epidemic. 1 in 11 adults globally have diabetes, 425 million currently. The situation only going to get worse in the next few decades. 80% of the diabetes burden is in low and middle income countries. But of course, no region in the world is spared the epidemic. And if we look at the major cause of death of our patients with diabetes, 2/3 of deaths are attributable to cardiovascular disease. So therefore, the challenge is, how can we reduce this burden of disease? And if we look at some recent data from the Swedish National Diabetes Register, over 2.3 million control, about 500,000 patients with type 2 diabetes. And if we look at all-cause mortality on the left, death from cardiovascular disease in the middle panel, death from coronary heart disease in the right-hand panel, patients without diabetes, shown in the black line, have shown a quite dramatic reduction in risk over the last 20 years. If we look at patients with diabetes, shown in the orange lines, rates have also declined, but they remain twice as high as in individuals without diabetes. And another analysis from the Swedish National Diabetes Register looked at, again, these are observational data, but they show that optimal cardiovascular risk factor control is associated with a reduced risk for ischemic events, but not for heart failure. So those patients who had their blood pressure, LDL, albuminuria, and tobacco use optimized had no increased risk relative to the controls, although heart failure was indeed increased. Now, for many years now, we've been recommending a multifactorial approach for modifying cardiovascular disease risk in our patients with diabetes. And if we look at the data to support this, really there aren't many studies that have looked at a multifactorial approach. The key one, of course, is the Statin trial, small study, just 160 patients with type 2 diabetes and microalbuminuria. The intensive arm had therapies to achieve targets in glycemia, lipids, blood pressure, and microalbuminuria. At the time, it was considered intensive, whereas in reality, this is what we're currently doing, or we should be doing, according to current guidelines. The original study had an 8-year follow-up, but we now have results of extended follow-up. And if we look at the 21-year follow-up, you can see significant reductions in all-cause mortality, cardiovascular disease mortality, retinopathy, macroalbuminuria. So clearly, a lot of benefit associated with this intervention. And perhaps most impressively, if we look at cumulative mortality over the 21 years, participants in the intensive therapy group survived for a median of 7.9 years longer than the conventional therapy group patients. Now, with regards to glycemia, of course, our best evidence is in patients with type 1 diabetes, where intensive glycemic control significantly reduced the risk of both micro and macrovascular complications in the DCCT. In patients with type 2 diabetes, the data is not as clear-cut. If we look at the original UK-PDS study, ACCORD, ADVANCE, and VADT, none of these trials individually showed that intensive glucose control resulted in significant cardiovascular benefit. However, if you look at long-term follow-up of the UK-PDS or VADT, or if one looks at a meta-analysis of these individual studies, there was indeed significant reduction in cardiovascular events. And as you're probably all aware, in 2008, the FDA had a guidance that all new anti-hyperglycemic agents have to demonstrate cardiovascular safety, and we now have the results of about 20 completed trials looking at individual agents. Now, these are going to be dealt with in great detail in some of the other presentations, but just quickly to review, with the DPP-4 inhibitors, there was cardiovascular safety, but not superiority, although there was increased risk of hospitalization for heart failure observed with saxagliptin in the SAVOR trial. If we look at the results of a recent meta-analysis by Gouache Swaby and colleagues, if we look at the GLP-1 receptor agonists overall, significant 12% reduced risk of major adverse cardiovascular events, or MACE. SGLT2 inhibitors, an identical 12% reduced risk of MACE. If we look at heart failure events by the GLP-1 receptor agonists, overall reduced by 9%. If we look at SGLT2 inhibitors, they reduced heart failure events overall by 32%. So if we look at guidelines around the world, including the recent update to the Diabetes Canada guidelines, they all give preference to certain agents, primarily the GLP-1 receptor agonists and the SGLT2 inhibitors, in patients with atherosclerotic cardiovascular disease, chronic kidney disease, heart failure, or over the age of 60 with multiple risk factors. So let's move on. And what about blood pressure? And as you can see here, organizations around the world recommend fairly tight blood pressure targets in our patients with diabetes. This is one situation where our guidelines vary. Some organizations recommend a systolic of 130, others 140, with the diastolic targets generally being less than 80. And if we look at the evidence, here you see results of a meta-analysis of 16 different trials comparing intensive versus less intensive blood pressure lowering. You can see that intensive blood pressure lowering associated with significant reductions in all-cause mortality, major cardiovascular events, myocardial infarction, stroke, CV death, and albuminuria progression. Although interestingly, in this meta-analysis, non-CV death, heart failure, and end-stage kidney disease were not reduced significantly. With regards to lipids, if we look at our statin trials, we have evidence from the cholesterol treatment trialist collaboration that every 1 millimole per liter reduction in LDL cholesterol results in similar benefit both in people with and without diabetes. a 21% reduced risk of major vascular events, and a 9 to 13% reduction in all-cause mortality. The Improve It trial, which looked at the addition of ezetimibe to a statin, in this case simvastatin, in patients post-acute coronary syndrome. You can see the patients with diabetes in orange. They had a higher event rate and a 14% reduced risk with the lower LDL achieved with the addition of ezetimibe. And interestingly, there's really no benefit observed in the patients without diabetes in this trial. More recently, we have evidence from the trials with the PCSK9 inhibitors. Here you see results of the Fourier trial with evolocumab, patients with diabetes at baseline on the left, those without diabetes on the right. Those people with diabetes had a higher event rate. As you'd expect, there was a similar relative risk reduction and a greater absolute risk reduction in those patients with diabetes. And based on these various trials, guidelines around the world recommend fairly tight control of LDL in our patients with diabetes. Our current Diabetes Canada guidelines recommend an LDL at least less than 2.0, and other organizations recommend even lower LDL targets. We now also have evidence beyond LDL. The Reduce It trial took patients with either cardiovascular disease or diabetes and another risk factor who had relatively optimized LDL levels on statin, but mild to moderate hypertriglyceridemia, and randomly assigned them to the addition of 4 grams of IPE, icosapent ethyl, or placebo. And as you can see here, the primary endpoint, which was MACE plus, was reduced by 25% with an absolute risk reduction of 4.8%, so a number needed to treat of just 21 over about 5 years. If we look at the key secondary endpoint, the more traditional MACE, 26.5% relative risk reduction, 3.6% absolute risk reduction. And if we look at subgroups, you can see similar benefit both in those people with and without diabetes. What about anti-platelet agents? Well, we have a lot of studies showing that in patients with diabetes without known cardiovascular disease, overall, there's no net clinical benefit. Here you see the results of the Ascend study. And if you look at the top of this slide, you can see there was a significant cardiovascular risk reduction. However, if you look at the bottom of the slide, you can see there was also an increased risk of major bleeds. So overall, the absolute benefit from avoiding serious vascular events were largely counterbalanced by the increased risk of bleeding. There was no group in which benefits clearly outweighed the risks, and therefore we generally do not recommend the routine use of low-dose aspirin in our patients with diabetes without known cardiovascular disease. And even in our patients with diabetes with known cardiovascular disease, the benefit is actually less than in patients without diabetes. We now also have evidence with dual antiplatelet agents, primarily with the addition of ticagrelor to aspirin. The Plato study in patients post-acute coronary syndrome showed significant reduction in the primary endpoint with dual antiplatelet therapy relative to aspirin alone, although there was some increase in bleeding, and similar benefit in people with and without diabetes. The Pegasus trial in patients with prior myocardial infarction again showed similar benefit in patients with and without diabetes. Again, some increased bleeding, but overall net clinical benefit. Most recently, we have the results of the Themis trial, which was done in patients with stable coronary disease and type 2 diabetes, but who had no prior MI or stroke. And overall, the combination of ticagrelor and aspirin showed a significant reduction in cardiovascular events, but an increase in major bleeding events. So overall, no net clinical benefit. However, there was a more favorable net clinical benefit amongst those patients with prior PCI. We also have evidence with novel anticoagulants. The COMPASS trial took a large group of patients with stable coronary disease or peripheral arterial disease and randomly assigned them to the aspirin plus rivaroxaban, 2.5 milligrams BID, or rivaroxaban alone or aspirin alone. And you can see if we look at the primary MACE endpoint, here you see results in people without diabetes. And once again, those patients with diabetes had a higher event rate, but similar relative risk reduction and greater absolute risk reduction. And importantly, if we look at a broader composite, which included not just MACE, but also MALE, major adverse limb events or major vascular amputations. Again, here you see the results in people without diabetes. And at the top, you see those patients with diabetes, 27% relative risk reduction, 2.7% absolute risk reduction over about 3 years of follow-up. And here, if one looks at net clinical benefit, again, overall clearly showing benefit in the patients with and without diabetes. So how do we put this all together? So we have many potential interventions. So in our patients with known cardiovascular disease, you can consider there's residual cholesterol risk, inflammatory risk, thrombotic risk, triglyceride risk, and we didn't talk about it, but LP little a risk. And there are a number of interventions that have been shown to reduce these risks. The bold study names are studies that are completed. The italicized ones are studies that are still underway. So if we put this all together, and here you see a summary of the potential benefits of proven secondary prevention therapies, you can see we have many interventions that can lower MACE, can reduce all-cause mortality, can reduce stroke, and can reduce myocardial infarction. And in fact, if you add these all up, the reduction in all-cause mortality is greater than 100%. So does this mean that we will make our patients immortal if we employ all of these risk reduction strategies? Well, first of all, can we do this in practice? And here one sees results of a recent study done in Denmark, and they looked at eligibility and preventive potential for new evidence-based cardiovascular drugs in secondary prevention, patients with ischemic heart disease on the left, those with myocardial infarction on the right. And they found that 80% of their patients with ischemic heart disease and 99% of those with prior myocardial infarction were eligible to receive one or more of these newer agents, with 37% and 80% respectively eligible for 4 or more new therapies. So how do we choose? Well, when it comes to prioritizing secondary prevention strategies, it's difficult to ascertain comparative benefit given the fact that these studies had different patient populations with varying trial-designed endpoints and durations of follow-up. The studies to date have generally evaluated these agents individually and have not investigated whether combinations of these new preventive drugs could provide synergistic benefits, and clinical trials commonly just add a new medication to the existing standard of care regimen, and it's possible that the new drug could obviate the need for prior agents considered standard. And of course, the estimates of benefit do not consider differences between efficacy measured in the trials versus the effectiveness of these new drugs in community practice, the potential adverse events associated with the widespread use of these novel therapies, such as, for example, bleeding events, the individual patient's underlying risk and comorbidities, the cost of the new drug. So therefore, to summarize, how do we prioritize treatment in order to minimize cardiovascular risk? Well, the good news is we are now blessed with multiple evidence-based strategies to decrease cardiovascular events in our high-risk patients with diabetes. So appropriate choices in a given patient will depend on the degree of abnormality in the risk factor. So if the LDL is very high, if the blood pressure is very high, although for some of these risk factors, for example, anti-platelet agents, we don't typically measure platelet function. The physician comfort with the intervention, of course, cost and access, and patient preferences. So in summary, we now have a lot of evidence that we can dramatically reduce the risk of cardiovascular disease in our patients with diabetes. Our challenge is knowledge translation to get the benefits of these drugs to our patients at risk. Thank you.